again, it's something that's pretty easily determined. Todd does not appear to be any respiratory distress right now, but if he were audibly wheezing, if he were working to breathe, if he were sitting up and leaning over, pursing his lips, or if you were able to see the sternocleidomastoids or the intercostal retractions on your patient, those are just some things that you look for. That's the inspection part of it. So you inspect first, and whenever you guys are in lab, we'll go through this too, you inspect as much of the skin as you can see. So like in males, you probably have them take their shirts off. In females, you can either have them gowned and have them pull their gown down and hold it, and then pull their gown up and hold it so that you can listen to the lower lobes and the upper lobes. So I'll have Todd turn around. So inspection posteriorly is going to involve, again, looking for retractions. Can I put your shirt?
Yeah.
Okay. So you're gonna. Okay. So you're gonna. And my hands are ridiculously cold. I'm sorry. So I'll try to warm them up here. But you, whenever you're inspecting for lesions, you're inspecting for surgical scars, for bruising, for trauma, flail chest, things like that. And then palpation. So palpation starts anteriorly and posteriorly. You palpate down the spinal processes, assessing for any tenderness, and then you palpate the ribs, assessing for any tenderness. Anteriorly and posteriorly. We'll just do posterior for now. Then you're going to check for anterior posterior diameter, which on Todd is normal, but if it looks widened, then you think of things like what? Right, COPD. So then you check for excursion. So I usually just have my patients take a deep breath and observe. So take a deep breath and blow it out. So his ribs cage seem to move symmetrically. So then you place your thumbs on either side of the spinous process, usually about 1 centimeter apart, and then you hook your fingers to the side and have your patient take another deep breath and out, and you can see my thumbs moving in and out, and everything moves symmetrically, and that's what you're looking for. So that's the inspection and the palpation. If you want to combine 2 exams to make it easy, you can also do your CVA tenderness here. CVA tenderness here. Remember, that's part of the abdominal exam. If you're combining stuff, it's usually easy to do that kind of at the same time too. So that's inspection, that's palpation. And remember, you do it on the side, you press the ribs. I'll have you flip around. So palpation on the front involves palpating the clavicles and the ribs and the sternum and the sides, just asking, or do you feel any tenderness when I'm pressing on your ribs? And same thing for inspection. So next, I move to auscultation. You can do percussion next if you want to, doesn't matter. But you want to auscultate in at least 10 places. So I usually pick 4 anterior and 2 lateral in the front and the back. And remember that it's important to compare both sides, so you're moving from left to right or right to left. You're not going down and down, because you compare.
How many did you say in the front you usually do?
4 in the front, 2 in the side, so at least 10 in the front and 10 in the back.
Gotcha.
So whenever you start to auscultate anteriorly, and of all days I forgot my stethoscope, but I'll pretend.
I got mine.
You can use the same, okay, yeah, thanks. So you can use the same words that we talked about last week or week before last, where we said, whenever you feel my stethoscope touch your skin, take a deep breath in and out of your mouth. That's important that they become mouth breathers at this point, because if they're breathing through their nose, you might get some sinus noise that will throw you off a little bit. So you can use that. So whenever you feel my stethoscope touch, you take a deep breath, say that. You start your anterior auscultation, and you don't have to do deep breaths right now. But start your anterior auscultation superior to the clavicles, so you get the apices of the lungs, so left side and right side, and it's always under the clothes. And I know you guys have all seen and probably done, I'm guilty of it too occasionally, where you listen on top of clothes, but don't do it. Do your patient the justice of making sure that you listen underneath clothes. So then I start, and again, I'll auscultate 2 points, so that's 1, 2, 3, 4, and usually I'll displace out a little bit, 5 and 6, and then lift your shirt up just a little bit, and then inferior 7 and 8, so that's 4 in the front, laterally. You listen about the fifth fifth intercostal space, and then slightly lower to get the lingula. And then this is the lateral sides. This is where you can listen 2 on each side and then compare 2 on each side. That's fine. But remember, you're getting about fifth space and then lower, so you get upper lobe and lower lobe. Now in the back, I'll try to turn around. Same thing. Let's start. Sorry. So you'll have your patient hug themselves, kind of like what he's doing, like this. So you'll see the scapula are pretty far displaced laterally. It just gives you more surface area to listen to. So again, you'll start and take a breath here. 3, 4, 5, 6, 7, 8, and you're at about 10 right there. And then, so that's that. Yes.
On the anterior side, do boobs just get in the way, or can you go through them, or?
Yeah, so whenever you have, whenever you have a female patient, what you can do is, again, you can have them draped using, either have them with just a bra on, or usually what you want to do is have them have a gown on. And so most of them will tie in the back. You have them untie it and bring it down and hold it just as far down as they feel comfortable. That way you can get usually 1, 2, 3, 4, 5, 6. And then you have them pull the gown up to the breast level, and then listen anterior
Underneath,
like that.
just go
right
around.
Underneath, and have them, move their breasts up, or you can do the hook thing where you have them displaced laterally. That's fine. Most women are pretty comfortable with that. That's auscultation. So then we are going to do percussion. Now remember, percussion on the lungs, you're mainly going to be hearing tympani because it's air filled. Yes, ma'am?
When you're listening, you're just listening for anything that's abnormal, and also just making sure that it's normal on both sides.
Yeah, so when you're listening for good air movement. You're listening for an average sound breath sounds, because you can also, with things like emphysema, where you have stiffened, hardened, hyperinflated lungs, you can hear decreased breath sounds. And so that's just when they're really quiet, and that's abnormal too. So she'll edit it out, it's okay.
Production value, Todd.
You'll listen for abnormal sounds called adventitious breath sounds, where it could be wheezing, both inspiratory and expiratory. It can be rhonchi, which you might be able to hear on me or David today if we've got a lot of thick mucus in your main stem bronchus or your bronchus. And that sounds like a kind of purring or gurgling noise. You can listen for ralls or crackles, which is the same thing. That was the one where it sounds like your hair rubbing together, and that's usually excessive fluid in the pleura. That can be inspiratory or expiratory. So you're listening for things like that. If you hear those abnormal sounds, it's almost always going to buy you more tests, whether it's percussion or chest x-ray or PFTs or something like that, whenever you see something abnormal or hear something abnormal. So that's what you're listening to. And those sounds, there are some demos available in your PowerPoint and at easyauscultation.com, and SAM have examples so that you know what you're listening to. So let's talk about the percussion. So percussion, you percuss in the same spots as you auscultate. And you guys remember with percussion, you use your third finger as a pleximeter and your third or second fingers as the hammer. And now for this, you're not going to be listening for different sounds again unless there's something abnormal. This, in the lungs filled with air, you expect tympani throughout. So you percuss. Something like that. And then on the posterior, again. And then laterally, you have your patient lift their arm. 2 spots here. 2 spots here. And again, all normal. Where you may hear dullness for instance, this is why I always auscultate before I percuss, is that if I hear rhonchi or an area of decreased sounds, when I percuss, I'm gonna pay special attention to that area. So if it transitions from tympany to dullness, it may tell me that there's an area of consolidation, for instance, a pneumonia, or a bleb, or a tumor that could be sitting in the lungs. And that's when we start using these specialized tests that we talked about a little bit in class. And again, it's good for you guys to know these, but you may not use them, and they're not used as often because we have chest x-rays now. But I have used them for documentation's sake. So some of those, we'll see, we'll talk. So we can talk about whispered pectoriliquy, that's where you whisper 99. So normally the lungs don't transmit sound really well. They're filled with air, they just don't transmit sound. But whenever you have something in the middle, like a mass of some sort of, again, a pneumonia, a bleb, a tumor, it displaces the air and sound is transmitted more easily. So normally, if you have your patient whisper 99, if you're auscultating, so you're listening and you'll have your patient whisper 99. So when you're listening, and you guys will do this so you'll get what I'm talking about, it'll be this muffled and you'll barely hear it. But if it's abnormal, you'll hear it better and it'll be clearer. That's whispered pectoriliquy. There is egophony, where you have them say E when you're listening, so say E. And it's usually at the spot where you're suspecting something, but again, you'll compare that. If you hear E, just like what they're saying, that's normal. If it turns into a or even like a rattling sort of kind of noise, that is abnormal. That means there's an area of consolidation. There's bronchophony, and again, that's saying 99. If, I always get this one mixed up in my head, hold on a second. If it's an area of, oh, I gotta talk about cyanosis too. Remind me to talk about cyanosis, I forgot. If it's the muffled sound for bronchophony, it's again, you have them say 99. It should sound muffled because the lungs don't transmit, but if it sounds clearer, then that's abnormal again. Tactile fremitus, I'll be turned back around. You use the ulnar sides of the pads of your hands. Say 99.
99.
That's that. And you guys did that already in class. So you should feel a vibration. If you have something solid underneath there that will transmit the vibration a little more, like a consolidation or pneumonia, you'll feel increased vibration. If it has less vibration, then it could be something like a fluid that is absorbing the vibration and making it feel less prominent to your hands. So, and that's where comparing is going to help you, because it feels more prominent on one side but less on the other. And again, very rudimentary tests, but stuff to know about. One thing I forgot to talk about when I was talking about observation was cyanosis. So there's two kinds of cyanosis. There's central cyanosis, where it tends to be the lips and the tongue, and then there's peripheral cyanosis, where it is the fingers or the toes. So central cyanosis becomes apparent in the lips and the tongue and near the frenulum whenever the oxygen saturation levels get to be less than 85%. And that usually implies either a cardiac cause or a respiratory cause. The peripheral cyanosis tends to be blue fingernails, blue toenails, blue extremities, or dusky appearing extremities, and that is usually a vascular thing, an arterial clot, a venous problem, and less so respiratory issues, but it can be. It can progress from central very severe to peripheral. That can also occur with hypothermia, whenever the extremities become blue or cold. Let's see if that's everything. Talked about a lot of this stuff in class, And chest x-rays, yeah. So, let me make sure I haven't forgotten anything. And clubbing, so we inspect the fingernails for clubbing as well. And so let's do this. Let's head over to lab. I will print out, unless you guys have them, you probably don't, the checklist, so we can go through the pulmonology checklist